next speaker is Miss Kenisha Gupta. We are all here to listen to her. She is a pre-med psychology major. She is an athlete par excellence. She's on the Dean's list of Northwestern University, and she's going to talk on the mind and diabetes.
Okay, I'm going to talk about the P word today. So if nothing, I want you all to at least laugh at my jokes. So that'll make me happy. So today I'm going to talk about diabetes from a slightly different perspective, because diabetes, more than most other conditions, I would say, is lived almost entirely outside the clinic. Most of what determines what patient outcomes doesn't happen during the appointments themselves. It happens in between appointments. So despite consistent and appropriate treatment, hopefully, outcomes can vary drastically. Diabetes is a lifelong condition, as we know, that is dangerous in the long term, but often asymptomatic early on. Many patients feel normal for years, and there is no pain signaling emergency, no immediate feedback reinforcing behavior. From a biological standpoint, this is well understood. But from a psychological standpoint, how do I go back? Yeah, got it. From a psychological standpoint, it creates a fundamental mismatch between medical urgency, that is long-term complications in this case, and experienced urgency, that is feeling normal today. Human cognition evolved to respond to immediate threat, not abstract future risk. Diabetes asks people to act urgently in the absence of feeling any urgency. So this tension lies at the heart of diabetes care, and this is where health psychology becomes relevant. Health psychology is not therapy, and it is not about diagnosing mental illness. It is a behavioral science that asks how people interpret illness, how they make sense of risk, and how those interpretations shape behavior over time. The central assumption here is that people usually behave rationally within their own understanding of the situation. So early public health did not operate on this assumption. For a long time, the dominant idea was simple: knowledge equals action. One of the first major challenges to this idea came in the 1950s during tuberculosis screening programs in the US. Screening was free, accessible, and the disease was serious. Educational campaigns were widespread. Still, many people did not show up for screening. Psychologist Godfrey Hawkbaum studied this problem for the US Public Health Service, and instead of asking people what they knew, he asked them what they believed. He measured whether people felt personally vulnerable to tuberculosis and how serious they believed it would be for their own life. What he found was quite striking at the time, although it might seem quite intuitive to us now, today. So two people could have the same information, yet behave completely differently. Those who believed they were personally at risk were far more likely to attend screening, even when knowledge levels were identical. Knowledge alone did not predict behavior, perception did. This insight became the foundation of the health belief model, which proposed that people act based on perceived susceptibility, severity, benefit, and barriers, not objective risk. Let me give you a concrete example of this. So hypothetically, let's say my dad told me about this conference and said he was going to sign me up as a speaker. I was like, oh my gosh, Dad, no, I can't do that. I can't speak in a room full of some of the best doctors in this country. I'm terrified of public speaking. Fast forward a few months, I've graduated college, I'm back home, and someone in my building wishes me good luck for this talk that I'm supposedly doing. I panicked. Surely this was a misunderstanding. Maybe Dad didn't hear me when I told him I was too nervous to do something like this. That was not the case. I called Dad and he was like, Keisha, this is an incredible opportunity, so high perceived benefit. Everyone is afraid of public speaking. You just need practice. So low perceived barriers. In diabetes, this framework is highly relevant. Many patients feel physically well. Some have seen diabetes in family members who lived normally, and complications feel distant and abstract. From the patient's perspective, urgency feels low, not because they don't care, but because their lived experience does not signal danger. If behavior follows perceived risk, one implication is simple. Before we address behavior, we need to understand what the patient believes they're responding to. So once researchers realized that perception mattered so much, the next question was, where does this perception come from? Let me give you two statements, and I want you to tell me which sounds more serious to you. The first one is, there is a 20% risk that you will develop complications over the next 10 years. And the second one is, out of every 5 patients in your position, 1 will develop complications over the next 10 years.
Second one.
Yes, okay. So although, as you said correctly, although they're the same, the second one sounds far more serious, right? So Daniel Kahneman and Amos Tversky explored precisely this through a series of experiments. In one classic study, participants were given mathematically identical outcomes framed in different ways. Despite identical probabilities, people consistently made choices depending on how the information was presented. The numbers were the same, the emotional responses were not. This became known as the framing effect. The key insight was that risk is emotionally neutral, meaning emerges from context. In diabetes care, this matters profoundly. HbA1c values, percentages, and targets are not received passively. Patients interpret them through tone, comparison, and framing. 2 patients can hear the same number and walk away with completely different meanings. They are not misunderstanding the data, they are making sense of it through several bottom-up and top-down processes that I will discuss. If framing shapes meaning, then the responsibility is not just to present numbers accurately, but to help patients understand what those numbers mean for them. So, even when patients understand risk and perceive it as real, another challenge remains. People usually start with strong motivation, but struggle to sustain behavior over time. This led researchers to study how humans evaluate time. George Ainsley demonstrated a phenomenon called preference reversal. When given a choice between a smaller reward today, that is maybe $10, versus a larger reward later on, so $20 next week, people consistently choose the immediate reward, that is $10 today. Interestingly, when both rewards are far in the future, people choose the larger one. As the present moment approaches, preferences are flipped. So David Leibson later formalized this through hyperbolic discounting models, and the implication was powerful. Humans are not consistently patient or impatient. We are disproportionately influenced by immediacy. This is not a lack of discipline, it is simply how the brain wastes time. Diabetes exposes this phenomenon perfectly. The cost of management is immediate, effort, restraint, and inconvenience, and the benefit is delayed, preventing complications that are to come many years later. This temporal imbalance makes sustained behavior extraordinarily difficult. If humans are wired to prioritize the present, then effective care must include benefits that patients can feel now, not only risk that they may face later. So even when motivation remains, diabetes requires something else entirely: continuous self-control. Roy Baumeister and his colleagues studied how self-regulation works through a series of now classic experiments. In one study, participants were brought into a room filled with the smell of freshly baked chocolate chip cookies. Some were allowed to eat the cookies, and others were instructed to resist the cookies and eat plain radishes instead. It's quite cruel, but afterward, all participants were given an unsolvable puzzle, and they were told to keep trying as long as possible. Those who had resisted the cookies earlier gave up significantly sooner. Their willpower had already been taxed. The conclusion was not that self-control disappears, but that it is effortful and fatigue-prone. In diabetes, this is highly relevant. Every day requires restraint, food choices, monitoring, medication timing, with no endpoint. Over time, this leads to fatigue. What we often describe as diabetes burnout is not a lack of concern, it is cognitive exhaustion. Early self-regulation research compared willpower to a muscle, something that can be fatigued but can also be strengthened with repeated use. Newer studies have shown that what improves is not the supply of willpower, but the development of habits, routines, and systems that reduce the need for constant control. In diabetes, this distinction matters because long-term success rarely comes from trying harder. It comes from making self-management easier. If self-regulation is effortful, then simplifying a plan is not lowering standards, it is improving feasibility. So finally, researchers recognize that people do not experience illness as physiology, they experience it as meaning. Howard Leventhal proposed that patients form internal models of illness, beliefs about cause, timeline, seriousness, and controllability. Across decades of research, these beliefs were shown to strongly predict engagement and adherence. To make this idea more concrete, I'll give you a very simple example. As children, we are told an apple a day keeps the doctor away. And me, I would always respond by saying, well done, I guess I'm not eating any apples because I don't want to keep my dad away. The message was clear, eat more fruits and keep the big scary doctor away. But my internal model of what doctor meant was completely different from that of most other kids. To me, that was my dad. People don't receive information as intended, they receive it as interpreted. In diabetes, patients may believe it's genetic, nothing I do matters, it's mild, I feel fine, or maybe stress caused it. My food habits aren't the problem. Each belief leads logically to different behaviors. From the patient's perspective, though, their choices make sense. When behavior seems confusing, it often reflects an internal model of the disease that is different from your very sophisticated medical understanding of it. So, these theories are not competing, they describe different layers of the same experience: perception of risk, interpretation of information, valuation of time, capacity for sustained effort, and meaning of illness. Together, they explain why diabetes is so demanding. Patient behavior is not random, it is patterned, predictable, and human. This understanding does not ask clinicians to become psychologists. In fact, many of you already use this reasoning intuitively. Health psychology simply gives language to it. When care aligns with lived experience, engagement improves, frustration decreases, and long-term outcomes also gradually improve over time. So the message today is not to add formal psychological care to your practices. It's that diabetes care already operates within a psychological system, whether we name it or not. Thanks. Thank you.
Very well spoken on your maiden run. I assure you a few more visits like this to the stage and you won't be able to stop talking like the rest of us.
Thank you.
Are there any questions or comments? One brief, please, if anything at all.
Sir, I've been sitting since morning here. Madam said that we are not very clear, a lot to be learned. A previous speaker says that when he started, he was confused, and at the end he was more confused. We are learning from morning, since morning, I think just before lunch, we are more confused and we don't know. 4 days back, I attended a seminar and they said that only with plant you can totally reverse diabetes. Today, I'm still confused whether to treat, what type of treatment should be given. Should we start with metformin? Should we give semaglutides? Or where do we stand today? I would like your comment, sir. Thank you.
That is the practice of medicine. All right? That's how it works. It changes from day to day and minute to minute.